a wonderful panel, a full panel. Why don't you guys come on down? And as you hear me read your name, kind of hold up your hand because the area of expertise runs the gamut. These are some of the greatest minds around in this field. Dr. Andrew Evans. Dr. Evans, this is Dr. Evans, Director, Thoracic Radiation Oncology for the Continuum Cancer Centers of New York. His area of expertise is in advanced radiation techniques for lung cancer. Dr. Larry Fabrizio, did I get that right? Fabrizio. Director, Pulmonary Faculty Practice. Dr. Fabrizio is a seasoned clinician with a strong academic background with more than 2 decades of private practice in New York City. Dr. Gomez. Dr. Gomez, nice to see you again. Dr. Gomez's area of expertise is incorporating new therapeutic agents into the standard lung cancer treatments with the goal of improving outcomes. Dr. Timothy Harkin. Dr. Harkin. You have a fan club, my dear. Dr. Harkin is working on a new, less invasive treatment to help people suffering from chronic obstructive pulmonary disease, better known as COPD. Dr. Mary Sullivan. Mary's one of my favorites because I quit smoking 10 times before I quit smoking. Mary's area of expertise is smoking cessation, asthma, and COPD. Then we have Dr. David Yankelevich. David is right here, Director of the Lung Biopsy Service. Dr. Yankelevich, oh yeah, make him feel at home. Focuses on diagnosis of early lung cancer via biopsy, advances in technology of rapid advancement of pulmonary lesions discovered on the CT scan. And he'll put that in much more understandable terms later on. And Annie, where are you? Annie, why are you down there? Annie. Annie, you can stand up here because I'm getting ready to sit down. Annie is a nurse practitioner, Division of Thoracic Surgery. These people can answer between them. Among them, they can answer any question that you could possibly have about lung cancer. We have mics at both ends. Don't be shy. What are your questions? If you are shy, just stand up and holler them out. Yes, ma'am. Speak up.
Do you recommend screening for people that are not at high risk? If so, how often do you recommend screening? Like breast cancer, you get a mammogram once a year, colonoscopy, just wondering what your thoughts are.
Anybody take it?
Well, this is still an area of controversy, and what I'll give you is my opinion. We're doing a study on never smokers that have been exposed to secondhand smoke. And we've shown that if you've been exposed to extensive secondhand smoke, you have a higher chance of having emphysema, you have more of a chance of having lung cancer, you also have more of a chance of having coronary artery disease, and probably all the host of other diseases that are related to tobacco. So I would say, and in Japan, everybody gets a screening CT or a chest x-ray starting at age 40. If you're at low risk, perhaps you could start at 40 and maybe have one every 5 years. These are still topics of research, and we are doing research in that area. If you're a smoker, then really, if you've had 20 years of smoking exposure, you start being at risk of lung cancer. So that's why you really have to have a discussion with your physician because there aren't papers on all of that yet available. And it's clearly an area of controversies.
I'm just curious, the cost, if it's not covered by insurance, for example. I doubt it is covered under my insurance policy. Did you say it's like $300? Is it that inexpensive?
That's what I paid. That's what I've paid every year. I'm now in like my 9th year. Yes, I've never paid more than $300. And guess who reads my scan? The best scan reader in the world. So I know I'm good.
Is that without being, you're saying $300 out of pocket without insurance? Is that what
My
you're-
insurance just happened. I have very good insurance. If I get lung cancer, they'll cover it. But they won't cover the year-to-year screenings. But Claudia just told me something I didn't know. Next year, under the Affordable Care Act, I'm also finally now in the Medicaid group. They may start covering it all of a sudden just because I'm 65 now, you know? Girl, black don't crack. And if I can just keep lung cancer out of my body, I will be good to go for a long time. Did she answer your question? The $300,
So
that's all I
it's
pay.
$300, and for those at low risk, you know, the insurance companies may not be covering it in the near future.
Yes, sir. Please take the mic.
Yes, okay. Can you explain nodules in my, that I have in my lungs, like what they start off as? I don't smoke. I never smoke. And I'd just like to know an explanation on that. And,
Larry?
you know,
Tim?
do I have to go for a yearly checkup for that, for CT scan? I was told before that like CT scans are supposed to be high radiation. So that's phony.
I mean, so basically, I'm a people doctor, and you know, we see patients who come with questions like yours, and so if somebody says you have a spot in the lung, clearly somebody's going to be nervous about it. And we talk to the patients and find out what your history is. If you're not a smoker, when a nodule is basically an X-ray finding of a dot. And so sometimes those are for benign reasons or for malignant reasons. And I think it takes a lot of work with the patient to figure out exactly how many of these spots there are, the scanning shows that, and what spots are malignant or not. If a spot is a solid spot, and we may want to look at that spot specifically for at least 2 years. If it hasn't changed, it's generally benign. If it's a fuzzy spot, we actually want to wait maybe 3 years to make sure that it's benign. But once you've had the spots in the lung, we will do follow-up scanning, and that's not really considered screening anymore. That's really kind of medical follow-up. And you could have had chicken pox, measles, or some infection in childhood and have spots in your lung that could never be seen on a chest X-ray. So as a clinical doctor, that's our job, is to try to explain it to the patient and also work with you so that you're comfortable with what's happening and make it make sense to you.
When it was followed up, it grew up to a certain size and then it stopped. You know, when they I had a rescan.
And so sometimes there are infections
it
that
stopped.
cause the spots, and they can go away with antibiotics. So again, not every spot is going to be a cancer, and you know, quite honestly, many of the spots that are seen are benign, more often than not, with the initial screening.
Yeah, and I think that's probably going to be one of the most common questions. Everyone says, well, I got to scan, it shows this, it shows that. Most things that you find on a CAT scan will be benign, meaning not cancer. So when you look at your skin, you have little imperfections, right? The same thing in your lungs, you're going to have little imperfections, especially if you're inhaling this New York air. You know, so you've got things that are scarring, old infections, you know, certain benign things that grow in your lungs. So if you got a CAT scan and they didn't find something that they said, oh, this is definitely a cancer, then you're in good shape. Now, when you're contemplating whether or not this is something suspicious enough where you need to have something done, that's where you don't want to be with someone that's trigger happy. And I'm a surgeon, and like I explain to all my patients, I like to cut people open, but only when it's appropriate. And so you want to be careful that you're not with someone that's trigger happy. What you want is someone that's going to look at it, say the risk of this being a cancer is low, either let's follow it or let's try with the needle biopsy. The best thing that you could possibly do is have someone like Claudia reviewing your scans where she's seen, I don't know, maybe millions of these things, where you can say, okay, this is not something you need to worry about. What you want to not do is be in a position where you get unnecessary surgery, unnecessary follow-up tests, et cetera. And that's why it's important to be with the whole team.
Is that possible that I could have
Yeah, sure.
Yes.
Yes, you can
Show
talk
up, she'll do it.
to Laverne there, and she will see to it.
Right here, we're going to get a question from this side of the room, but can you get her the mic? Can you meet her halfway? There you go.
Good evening. Dr. Flores, you went through, in your PowerPoint presentation, you went through all the stages of lung cancer and the treatment modalities, but you left out stage 4. Is that just the end? The patients die? There's no treatment?
Well, stage 4 is the most complicated one, and I don't like to touch on stage 4 because our main point is to catch it early so you can be cured. But there are many patients who have stage 4 who can live 8, 9 years later. I think the biggest thing when you look in the internet, you're going to see patients or stories of patients who died quickly. Now, when you're in my office, you will find people who have had stage 4 who are alive 6, 7 years later. Now, those are more the exceptions than the rule, but that gets into a whole different way of thinking about lung cancer. There are certain surgeries that I will do that most people will say, no, it's not worth it. This patient's got stage 4, they're going to die. But when you look at that individual patient, you can say, no, in this particular case, we should do this, follow it with chemotherapy, follow it with radiation, do these other tests that, and these other treatments that can keep that patient going for years. For example, in my office, I've got several patients who've had spread to the brain. And many people will say, well, if it's spread to the brain, that's it, you're done. Well, come to my office and you'll see people who are alive 8, 9 years later who've had spread to the brain. The only reason I don't go in depth about stage 4 is because the main point of this whole meeting is to talk about catching it early. But, you know, as an individual, if you have a cancer and you have walked into a doctor's office, then there is hope there. Now, if you're being wheeled in and, you know, you're gasping for air, there's not a lot that we can do. But if you've walked into a doctor's office with stage 4, there's stuff that can be done.
Thank you. Right there she is.
That was quick. If someone had cancer in some other part of their body, does that increase their chances of having lung cancer? I know some cancers make you more susceptible, I think, to others. I'm not sure about that either. So,
Dr. Gomez, you want to answer that one?
Well, lung cancer is one of the interesting cancers because it doesn't go along with a lot of other cancers. There are families that have lung cancer. Those are few and far between. There are some very rare syndromes of people who have different types of cancers with lung cancer. But the truth is that most cancers are in other areas of the body are separate from lung cancer. And so really the most important factor in terms of increasing risk of lung cancer is tobacco consumption. And in those 20% of people where we don't know why they have lung cancer, we don't really know. But in a sense, in a general sense, no, it does not increase your likelihood of having lung cancer.
Just holler out, you right here. Just give us your question because we want to get his, yes, ma'am. Just holler it out so we hear you.
I'm actually, I guess, looking into the viability of getting screening myself. I'm not really considered high risk because I don't smoke, but my uncle died of lung cancer. My mother is a lung cancer survivor. She actually, hers was caught, ironically, she had a chest x-ray that showed something. Eventually she had a CAT scan. That whatever showed up on the x-ray was not cancerous, but by doing the CAT scan, ultimately they found it. Actually, my mother was a patient of Dr. Gomez before he left for Florida, and she's still alive and doing great. She's on Tarceva. But, you know, I myself, I guess, have concerns. I was exposed to secondhand smoke, I guess, growing up. My mother gave up, you know, smoking more than 20 years before she was
Is
diagnosed.
your question, should you have a scan?
Yes.
You've heard the history. Anybody want to take that question?
So first of all, have you ever smoked? No. Okay, then we have a study that's available where we can provide it for free if you're a never smoker, and in your case where you have a family history. You certainly, and Laverne will be happy to take your name, and we would be happy to provide it.
Next question. Come on, honey, you stand up, and who, after her, who wants to do next?
Hi, I have lung cancer currently, and I got it because of the 9/11. I worked in that area, 2001, and I've did 4 rounds of chemo successfully, thank you, and now I'm doing some pre-op, and I'm gonna have surgery. My question to the panel is, there is a little period where the chemo is still working in the body, so I'm told. So is that about 30 days or whatever? That's part one. Part two is, what is that window that you have between the last chemo and the surgery?
So once you're done with the chemotherapy, if you're doing chemotherapy before surgery, the chemotherapy's out of your body very quickly. It leaves the body within 24, 48 hours. But the toxic side effects continue for some time. So the reason you can't have surgery immediately is just to let you recover from the chemotherapy. So there's no really specific amount of time. It depends on the patient, it depends on the surgeon, but usually it should be about 4 weeks after the last chemotherapy. Raja?
Yeah, and that's the thing. It's, you know, we'd operate right after chemotherapy, but we got to let it leave your system. So chemotherapy not only stops cancer cells, but it stops cells from healing your body. And once you have an incision in your chest and you have surgery done there, you need enough of recovery so that your body can heal itself. So just enough time to let the chemo get out of your body, and then we take you to surgery.
Yes. I was a first responder with my buddy here, John. He also spoke, and the young lady said she was at the World Trade also. We go to clinics. We go to the Mount Sinai clinic, and they seem to almost dictate when we should have our screening. So I would say my last one was in 2010, and they put it off. And there's some thought that by having a scan too often, this could excite your cancer. If there was one, and Dr. Harkin is my doctor, he biopsied me right away. I had surgery, and it just showed it as nodules. Is there any truth? Should I have it every year? Are the doctors dictating my medical outcome?
Anybody?
Thanks for coming, Mr. Kuhn. So let me back up a little bit. In terms of what the World Trade Center program does and doesn't do is really dictated by the federal government, and I believe it goes through NIOSH, the National Institute for Occupational Safety and Health. So their hands are tied to a certain extent, and that being said, they're learning as they're going along, and they are listening to the clinicians who are on the front lines taking care of the patients, and we tell them we need this, we need that, and they try to work with us to help provide the best care for all you folks who are out there as first responders. I think they do a very good job in a very difficult environment. But they have to deal with the politicians as well. That being said, my understanding at this point is that they have recognized the sort of recommendations that you've heard here today from the other speakers for lung cancer screening in appropriate groups. They are, as I understand it, in the middle of negotiations with NIOSH about this issue and about getting coverage for lung cancer screening CAT scans. So I can't guarantee that that's going to come down the road, but it's under active discussion. And in all honesty, based on experience with what we've seen over the past 10 years or so, with the success in the World Trade Center at expanding their care, and as you know, lung cancer is now covered under their program as a disease that will be paid for by the World Trade Center program, one of many cancers. We want to get you obviously before we have or early in the lung cancer screening portion. So that's still under negotiation. But I would expect, based on the way things have gone in the past few years, that that is going to come down the pike.
So I guess my other part of the question is, it's $300. I'm willing to spend the $300. Am I going to be overexposed, in your opinion, or the panel's opinion? It seems to be that it's worth $300 according to Raj. Am I, I heard this in the beginning, and you've heard of it in 2010, that we don't want to expose you to more than what we have to. The panel seems.
He's got the question. If he has it, is he going to get too much radiation?
I'm going to let one of the radiologists answer that question.
Good.
Okay.
So I'm going to try and answer the radiation question, because this is, you hear a lot about it in the newspapers. And here are the facts. We're all exposed to radiation in our daily lives. It's around us everywhere. It's in the earth. It's in the brick in the walls and the cement. It's coming from the cosmic radiation. The way to think about it is, I'm going to give you a few numbers to just sort of put in your mind. We measure it in a unit that they call millisieverts. That's the unit that we call the amount. And so if you live in New York City, for example, you're exposed just by living here to about 3 millisieverts every year in total. Every year you get another 3 just by living here. If you lived in a place like Denver, Colorado, where it's higher altitude, about 15 or 16 millisieverts every year. If you live in some places in Iran and Turkey and Rio de Janeiro, 50 every year, 50 millisieverts. So again, 3 in New York, 15 in Denver, 50 in some other places. The amount you get from a CAT scan, now a low-dose CAT scan is 0.5. 0.5 you would get from one. Nobody knows if that causes any damage whatsoever. There's no direct evidence whatsoever that doses that low can cause any damage at all. If you were to move from New York City to Denver and live there for 2 or 3 weeks, that would be the equivalent of getting a low-dose CAT scan, basically. So, yes, there is evidence that high doses of radiation can cause a certain percentage of people to have cancers. There's no evidence that something as low as a CAT scan causes any cancers. So I think that's one of the ways that you have to think about it. And while we hear a lot of information about how dangerous it is, I think it's been really hyped up. I think you have to go to a place that really specializes, that does these kind of scans, that understands low dose and provides low dose scans. And I think in those circumstances, the issue of radiation becomes almost minimal. People who are radiation workers who work in the field, by law, they're allowed 50 millisieverts every year because it's basically considered safe. 50 a year, and I'm talking about 0.5 in a low-dose scan. So it's a very low dose.
And I think it's important to see where the flip side is coming from. A lot of this radiation concern came from a study that appeared in the New England Journal of Medicine that compared the radiation you get in a CAT scan to the radiation you got from the bomb in Hiroshima. And I don't see how you can compare those two. Sure, there's a certain amount of radiation you get, but that's what they were comparing it to. And that's where a lot of the medical studies are trying to extrapolate from that. And I think those are two very different things. Well, another important point is I'm going to be very biased in my statements here, but I think the World Trade Center people, the people who were exposed down there, are a very different group. There was asbestos in the World Trade Center, and asbestos puts you at high risk for mesothelioma, which is a cancer of the lining of the lung, but even more for lung cancer. And so I think for the World Trade Center victims, of course, there's not going to be a set of guidelines, but if I had a family member, and actually I do, that was down there, I would make sure that they got screened every year with a low-dose CT.
Okay.
I just want to say, too, that not all CAT scans are the same, and the technology that is being utilized in this program is the lowest, and the definition that is obtained is among the greatest. So I think, not all aspirin are alike when it comes down to CT scans, and you really need to work in a center where they have an experience in both doing the scan properly and also reviewing the scan.
Got to take a question from this side of the room. Madam.
And actually,
Do you need permission from your doctor to get a scan?
Well, currently, yes, you need a prescription in order to get a scan for which you pay $300, yes. The only
But is it hard to get?
Well, it depends on the physician.
Oh, okay.
It depends. But I think if you were to come, we would recommend physicians that you could talk to if you have difficulties with that. Mammography is the only thing that you can come in yourself and say, I want to have it. But CT screening for lung cancer is not at that stage yet.
Yet. Now, madam, please, you've been waiting a long time, you better be quick.
It's actually not a question, it's a comment, and I wanted to thank all the members of the panel, especially the women, since it's Women's Month. But I want to thank you for your diligence on this particular subject of lung cancer. I just recently, and I mean very recently, lost my mother to lung cancer. My mother was a non-smoker, a non-drinker, and we walked into a hospital in the emergency room, and she was diagnosed with stage 4 lung cancer. Throughout her going to the doctor and everything, she had symptoms, but they didn't find it. And one of the things that her doctor said to me that stood with me while I watched that video and I listened to you all talk, and I said to her, how did this happen? How did we miss this? And she apologized and she said, I'm really sorry that we didn't find it. She said, but there's no mandate for lung cancer. Now, her apology didn't save my mother's life. Her apology doesn't make me feel any better today than the day that she told this to me in October. But I thank you. And my daughter and I were here. She saw this and she freaked out and she says, Mom, we gotta go. And, you know, we couldn't save my mother, but hopefully with the CT scanning, my family will be able to go and possibly catch, you know, the non-smokers and the smokers, because I have aunts and uncles who are still alive in their 80s. It's been smoking forever. They've come from the South, all in tobacco fields and all kinds of things. And my mother, who didn't do any of these things, is the one who did and lost her life. So thank you.
That is so sweet. Thank you. Sir, right here.
Also, thank you folks for being here. Just 2 quick questions, and whatever information you can give me would be helpful. The first one is, the procedure that you're discussing with the CAT scan, you say has quite a bit of cardiology information associated with it, and yet I'm a little surprised I haven't heard anything like that concerning, you know, people with heart conditions. After all, there's more people having heart problems than there is, I think, all these cancers combined. And I'm just a little surprised at that. I'm a little curious if you feel there's more that could be done in terms of that. I know you folks are cardiologists, but I'm just curious if there's anything that this can sort of pass into the area of cardiology that people could benefit from this, and why it hasn't really happened. The second question I have has to do with, there are a lot of new cancer methodologies out there now, drugs, genomics, that supposedly are particularly helpful, fairly new procedures. I wonder if you could maybe talk a little bit about that in relation to lung cancer.
Go ahead.
So maybe if I could talk to the cardiac. So we do see, when you go to a cardiologist and he looks at your coronary arteries, he does it in a certain way, which is at a higher dose, it's gated, there's certain procedures that go along with it. We do it at low dose ungated, so it doesn't provide the same information that cardiologists are used to. What we're now moving to, because the technology has developed, that we can do a combined cardiac and lung scan. We're just about there. So we can provide the information that the cardiologist is used to, as well as the lung part at a low dose. But that's a technology development, and hopefully cardiologists and radiologists work together. And we had Dr. Hecht here. Is he still? No. He left, okay. Because we have to work on that together.
So in terms of the treatment of lung cancer, in the past 10 years, the treatment of lung cancer has changed significantly. And that's mainly because we've recognized that there are many different types of lung cancer. Lung cancer isn't just one disease. The disease in people who have never smoked or have smoked very little is a very different disease from people who have smoked a lot. But even in patients who have smoked, there are different types of lung cancers. And we do genetic tests to identify those cancers. There are many people, right now it's about 20% of patients with lung cancer, who actually have genetically a very specific type of cancer that can be treated with new drugs that are not chemotherapy, that are less toxic than chemotherapy, that work significantly better than chemotherapy, and they're pills. And so right now, we're at 20% of lung cancers, and every year, we find new cancers that respond to these pills, and hopefully soon we'll be up to 100% of lung cancers where we don't have to use chemotherapy. So that is happening every day.
Can I have a show of hands? How many people in here smoke or have smoked? Okay, that's why you have to hear from Mary O'Sullivan, because she's helping people stop. You know that if you quit a long time ago, you still have to be screened, but please talk about the newest thing in quitting, because once we can do that or keep people from starting altogether, we'll be home free. Doctor.
Well, thank you. I think the important thing from the smoking point of view is that lung cancer is one of the few cancers that is in part preventable. So we really do have to focus very carefully on quitting smoking. The person who's smoking and let's say has a family history of lung cancer, or they have COPD or lung disease or they've had asbestos exposure and continues to smoke, is in real danger. And what I think is an important thing to keep in mind is that the person who's smoking in that situation and realizes their danger is facing a really, really terrible addiction. And it's not that that person doesn't have enough moral fiber to be able to have the willpower to do it. This is a really tough addiction. Anyone who's given up heroin will tell you it's harder to give up smoking than it is to give up heroin. So what we need to do is to identify the person who is smoking needs to identify the idea that they can quit. I think the thing that holds people back the most is that they really believe that they can't, because they know, let's say it's the morning and they're trying to get the kids out to school and they really love their morning cigarette with their coffee, and the bus is coming and everything's going wrong and you feel absolutely like hell. And you know that if you have a cigarette, within 10 seconds, you start to feel immediately better. The bad feeling goes away, and on top of it, you get pleasure. That's a very addicting situation. Not everybody has that. Some people can be casual smokers, and they can smoke on a Tuesday and not think about cigarettes again for, who knows how long. But most of us who are smoking in this day and age are people who are really severely addicted. So the thing is, let's accept that we have an addiction and realize that there is help, that you can quit. That's the most important thing that holds people back, because they really believe, I can't do it. And you really can do it. There's medication to help. We have better medication than we had years past. We understand it better because we know so much of it is genetically based, that it's how your body handles nicotine, and your body handles nicotine differently than another person. So we have to tailor what we do to the level of addiction that you have, get rid of the guilt, only look forward, and plan to be smoke-free as your best approach to preventing lung cancer. If you are a former smoker, we're very concerned because that effect is still there. It goes down a lot when you quit, but the risk is still there. So we have two groups of people. But the most important thing is to really give yourself a chance, because I can assure you that you will be able to succeed.
Questions? Okay, sir, right here. Stand up and holler it out.
My question is, like, if you stop smoking, for example, I stopped about 7 years ago, I've been smoking for 25, how does that decrease my risk for getting cancer now?
It decreases your risk very significantly, but it never goes down to zero. It always stays between 10 and 15% above baseline. So even years later, there's still that increased risk. So getting a screening lung cancer, a screening CAT scan is a very appropriate thing to do, because the risk never really goes away completely, but it goes down greatly. So you've done the great job, but the thing is, getting screened is a very important thing to do as well.
My dad quit for 40 years. He died of lung cancer. That's the lesson. Yes, sir, right here.
What's the recommendation on the protocol for repeat CAT scans? Is something you should be getting every year on and on? And is there any cumulative negativity associated with that?
Well, As best we can tell, given the rates of growth of lung cancers from the time they become visible on a CT scan, we would say you should have it every year. Now, if you're at much lower risk, then perhaps the time interval can be lower. But even the recommendations now for high-risk people are to do it every year, as long as you have a life expectancy of 5 years, you know.
Dr.
Danger with that, taking that every year, even though it's a low dose?
Well, we do mammograms. We've done mammograms every year, and there has never been a negative effect proven to that radiation dose.
Dr. Harkin, I'm curious, is there a correlation between lung cancer and COPD? If you get COPD, does that automatically mean you're going to get lung cancer?
No, is the short answer, but you are definitely at increased risk of getting lung cancer if you have COPD. And this is one of the things that makes quitting smoking so important, just to back up what Dr. Sullivan said. You know, everybody says, well, you know, I know my Aunt Tilly smoked 2 packs a day for 80 years, and, you know, she died running a marathon and was hit by a truck. Well, that's the exception to the rule. And, you know, 15% of people or so get lung cancer, 15% of people get emphysema, 15 to 20% of people get heart disease. Very few people get away without getting some element of cardiovascular disease or lung disease. So there is overlap between people who get COPD and lung cancer, and there is evidence that shows that if you have COPD from smoking, that you are at higher risk of developing lung cancer from smoking-related lung cancer than if you do not have COPD. But the overlap is not complete, and certainly not everybody who gets COPD is going to get lung cancer or vice versa.
Okay. You've been awfully quiet tonight. I want you to share something really profound with this group.
Honestly, most people say that's blessed relief.
No, not tonight.
A quiet New Yorker is an unusual thing. I think there are really 2 messages that are very important. And, you know, we've talked about the reluctance of, you know, medicine as a whole to really bring the screening program to, you know, to our patients, and Dr. Henschke's incredible work. And, you know, there've been a number of reasons for that in people's defense. One has been this sort of nihilistic feeling that, you know, if you get a lung cancer, well, you know, perhaps it's like prostate cancer. We can just watch this and see what happens. Dr. Henschke's data and data from others show that even if you're over the age of 80, if you get a early stage, the T1 lung cancer, the smallest one you saw, and you didn't treat that, it will be the cause of your death in the majority of patients. And that's like not treating a heart attack. So, you know, just taking a we'll just watch and wait approach is really not appropriate. The other point I want to make is, you know, Dr. Flores, you made the very good point that we really do surgery as the standard treatment for early stage lung cancers. But many physicians have felt, you know, our patients are older, they've smoked for a long time, their hearts are bad, their lungs are bad, they couldn't undergo surgery. So why screen them if I cannot take them to the operating room to operate on them? And that may apply to about 40% of people who actually get early stage lung cancers. And I'm the radiation oncologist, so I'm not a radiologist, I'm the guy who treats cancer with radiation, and I'm not as smart as a radiologist, obviously. But we do have these other techniques now for treating lung cancers where you don't require any form of anesthesia. You come in for 3 sessions only. They each take about 25 minutes. You're awake the whole time, and you simply need to lie still. And using these treatments, we can destroy the cancer in the lung in 90 to 95% of patients. So although it's not considered the standard treatment because surgery has some other advantages, don't feel that, you know, you're too sick or you're too old or you wouldn't want to go to surgery. Therefore, you're simply going to take the risk of having a lung cancer be undiagnosed. So I think it's very important that people are very proactive. And honestly, if your physicians are not responding to that, like all things medicine, it's very appropriate to get a second opinion. You should be very comfortable with the way you've been treated.
Excellent. I'm so glad you spoke up.
I didn't. You made me.
Any question, you guys can just stand and...
Of the 20% of the non-risk, my sibling had no risk.
I mean, she didn't smoke, she was a lifeguard. She got a piece of her lung cut out. So I'm wondering if there's a genetic underpinning. So I don't want to routinely, my internist doesn't feel I need to do anything. And I don't want to routinely, my internist didn't think I should routinely get a chest x-ray, and I don't really know at this point what to do. So that's one thing. Secondly, can I join a group, because I'm not good on computers, where I can find out the latest research in this area of lung cancer, because I would like to be informed.
So is that Sheila? Sheila, why not?
Yeah, they're bringing the mic. It doesn't matter. You can come up here or you can.
Is this on?
Yes, it is.
Okay.
Hold it closer.
I'm with Lung Cancer Alliance, as I should have mentioned more clearly before. And we're in Washington, D.C. We're there primarily because we're dealing with the political side of this issue. But we also have, no?
Not you, him.
Oh.
One at a time.
We also have patient support services. 50% of our work is patient support services. And by that I mean real live people on staff answering calls. So if you have any questions or want more information or material, you can call our 800 number. I left some of my cards up by the door. We also have a website, lungcanceralliance.org. So those are resources we have for you. And again, my card's up there. Call me. I'm happy to talk to you. And if I could take 1 second to add what Dr. Sullivan said. Dr. Sullivan made such perfect sense. One of the things I found with people who are still smoking, they say, oh, I'm not going to bother to get a scan because I've already done the damage. It's too late. Wrong. No. Get that scan, have it done. You'll also find that getting screened, you're going to be able to get very personalized help in stopping smoking. It's a teachable moment. When you see your lungs on that screen, computer screen, you're going to change your mind about smoking.
And if I could just reinforce that, I'm sure the patients in here, people in here are just smokers, but there are also people in here who have been diagnosed with cancer. It's incredibly important to quit at any point. If you quit in the week before you start your cancer treatment, you increase your chances of cure by up to 20%. So it's never too late, even when you are diagnosed.
Okay, we're down to the last 10 minutes. So let's talk to the people who have never asked a question yet. If you haven't asked madam, right there, yes, with the shawl and you and then the lady behind you.
I'd like to know how long
Are these microphones working? I can't hear a word you're saying.
Okay.
I'd like to know.
I'd like to know how long this technology of the low dosage CAT scan has been available, because as recently as last year, my sister had the regular CAT scan because she was a little bit nervous about her risk. I had a high risk. I had a high dose CAT scan about 3 years ago. And I think what's so frustrating about our whole medical system is that this information is not really out there. If a doctor feels that you are at high risk, you will just go to one of the local places that is doing various diagnostic testing.
Question, please.
So the question is, how long has this been available? Because I didn't even realize it was available until very recently.
Well, we started it in 1992. The Japanese have been doing it since roughly the same time, 1993. It became available to be done on any modern CT scan. So it's the problem of communication of the physician, the radiologist. That's why it's important to go to a a hospital or a setting where people really understand these issues. But it's been available.
And I think you hit the point right on the head. That's why we're having these meetings. That's why we're having these educational forums to let people know that this is out there. So many people don't know it's out there. And I think it's important for you to talk to people and let them know, listen, this is out there. If you see a smoker, let them know you can get a low-dose CAT scan that can potentially save your life.
Okay? Yes,
Oh,
ma'am.
I'd just like to start, of course, by thanking those of you who already know how many wonderful things you've done for our family. For the rest of us, they have this crew here has saved our mother's life twice over, and they are now saving my sister's life. Go team, and they are trying to keep me healthy. So we are terribly grateful. Thank you. And the second thing is, could you clarify for me anyway, and anyone else who's curious about the difference between small and large cell lung cancer, the incidence of it, and the sort of success rate of cure? What makes small cell so much more insidious than large cell, or anything else you'd like to add? Dr. Gomez,
Yeah, I
thank
think
you.
that, I get that question a lot. Is it better to have small cell or non-small cell? And the truth is that no cancer, lung cancer, is good. And non-small cell and small cell are probably equally bad. It is better, obviously, to have non-small cell if you have very early lung cancer. The difference between the two is there are a few differences. Small cell lung cancer grows more quickly, is more aggressive, but responds better to chemotherapy. We don't use surgery in the treatment of small cell lung cancer. We use chemotherapy and radiation. For non-small cell lung cancer, early stage disease, surgery is a very important part. Those are really the major differences. Now, one of the most important differences is that small cell lung cancer is almost 100% tobacco related. So it's very uncommon to have a patient with small cell lung cancer that has never smoked, while many patients with non-small cell lung cancer have never smoked. Those are the biggest differences. Was there something else, another part to the question? I can't remember.
Okay. One
Hello.
second. Annie, you've been kind of quiet down there. Will you grab a microphone? Nobody gets out of here without sharing. So grab a mic. You're here for a reason. Please share your area of expertise and something profound with this august body.
I don't consider myself an expert in any area.
Oh,
but,
please, just sit
so
close to the mic so we can hear
I
you.
work with Dr. Flores and his team of surgeons, and I guess my main job is to help patients get through the whole process. So I see the patients at initial consult. I see them, I'm in the operating room. I see them on the inpatient unit recovering from surgery, and then I see them after in clinic for follow-up, and then I sort of follow up with you after, when you're home. I call you to make sure you're okay. So I guess that's my area of expertise.
And it's real important.
Yeah, and I think, someone like Annie's very critical to the team, because as the surgeons, we're always in the operating room. So when you call the office, we have 4 nurse practitioners that you speak with, and one is Annie, and they can make the same decisions that we make. They have the same insight into everything that we do. The only difference is we operate, they don't. But when you speak to them, it's like you're speaking directly to us.
Now, madam.
Hi. I want to thank everyone. It was very informative. But to piggyback what this lady said, maybe you could make a public, what do they call those, advertisements? Yeah, public announcements. Like instead of in addition to the getting the free nicotine patches and everything, because this would be wonderful if people throughout the country would know about the CT scanning. Is that possible?
Yeah, see, it's a little bit of a hot topic. There are some people, as much as here, you hear all of us are big advocates for it, there are groups who are really violently opposed to it as well. I didn't say that. I did not say that. But so there's a lot more here than meets the eye.
So bottom line is, what he can't say, I can. This is very important. Don't let anybody bullshit you. For the rest of your life, they are preaching the truth. And you can reject it, but if you're at risk and you want to live to be my age and beyond, do what they say.
Well, and we would love to do what she was suggesting.
Yes.
We just wouldn't survive.
But that doesn't mean that we can't do it. That doesn't mean that citizens can't, start the ball rolling.
And that's where groups like the Lung Cancer Alliance are just, indispensable.
Got time for 2 more questions. Yes, ma'am. You, and there was one hand over here, right here. You'll be the last one. Yes, ma'am.
First of all, I want to thank the panel for being here tonight, and I want to thank Lung Cancer Alliance. Anyone in here who needs, who is a patient or knows someone who needs advocacy or needs information should definitely call, because after my dad passed away from stage 4 non-small cell lung cancer 4 years ago, this was such a wonderful resource. I wish I had known about this organization when my dad was sick, and we could have gotten the resources we needed then. Just wonderful, the advocacy trips to DC and the information providing advocacy for lung cancer patients and support. It was so meaningful in my life. I found that there was just, when my dad was diagnosed, there was just this chasm of mysteries and unknowns and just this death diagnosis from the doctor, his oncologist. In my question, my dad passed away, no cancer in the family. And then my dad's mom, my paternal grandmother, 2 years later at 91, passes away. She has hip fracture, she has all these things. Incidental finding, she has lung cancer as well, albeit 91 years old. So my question, is there a link, are there studies between heredity and lung cancer? And also, my dad did jobs with environmental toxins and also had a first cancer at age 45. Non-Hodgkin's lymphoma, where he had large dosages of chemo and radiation. Are there any studies also to that effect of environmental toxins and a link with lung cancer and also chemo and prior chemo and radiation in large dosages?
I'll take the first part, one of the parts of that anyway. So,
Speak up.
again?
You're so soft-spoken.
The problem with lung cancer is really sort of separating out the multiple toxins. Can you have a family history if you have an adult who smoked in the house, for example? Is it really genetic, or is it something that you were both exposed to, either the smoker and the secondary smoker? Hodgkin's is very different. If you get treated for Hodgkin's at a young age, your chance of developing another cancer is 28%. But Hodgkin's is the rare exception to that rule.
And it's a high-dose radiation, has nothing to do with...
It's,
with
yeah, I mean, these are
so
different...
the dose of radiation is not what you use for imaging studies.
Right. When we talk about therapeutic, using radiation as a tool to cure cancer, we talk about a very different animal to the radiation used in the low-dose CAT scans.
No, I definitely understood that. I'm a proponent of CT scanning. I just was asking if, like, the radiation my dad got for the prior cancer, if there's some studies for that. But I think there are. Okay. Yeah. And one last question that I have. Tarceva is being widely used now, and I just wanted to ask about that, how that's progressing. And my dad, there were a lot of things with insurance companies, and once the tumors had spread to his liver. So once his liver function was better, because they had to get his liver function up in order to actually be on the Tarceva. By the time the insurance companies and everything was on board, his kidney function was failing, so he couldn't do the Tarceva. How often do you see these type of things happening? Are they still happening? This was 2009.
I think Dr. Gomez should take it.
Well, those things still happen. The issue is that...
And I don't even know what Tarceva is.
Tarceva is a newer drug. It was approved, I think, in about 2006 for the treatment of lung cancer. It is a very important drug for some patients who have a specific change in their lung cancer cells, a mutation that makes them very sensitive to the drug. So that's one of the things that have been discovered in the past 10 years that have made lung cancer different. So about 10 to 15% of patients with lung cancer are very sensitive to Tarceva. I have a patient who's been on the drug or a similar drug for 9 years with stage 4 lung cancer, and she's doing still very well with no growth of her cancer at all. Now, it works like that only in about 10% of patients, though. It can work in patients without those changes or mutations, but it doesn't work as well as standard chemotherapy. So it's not really a great drug for patients who don't have the mutation. So unfortunately, it's for a small population.
Last question of the evening.
Oh, I was just going to share.
Okay, well, last sharing of the evening.
Oh, thank you.
Hi. I just also wanted to say thank you to the wonderful panel, especially my surgeon, Dr. Flores, because he's my hero and love him so much. I was a non-smoker, am a non-smoker. I suffered for many, many, many years, not being able to breathe, coughing and wheezing, and pneumonias constantly in and out of hospitals, and suffering and crying out for help. And I was misdiagnosed as having asthma. And in all those years, probably about 6 years, not one doctor suggested that I get a CAT scan. I was given x-rays in the hospital. I was begging for help on steroids. And finally, my intuition told me I needed a CAT scan, and I asked for it. And it showed that I had a rare type of tumor called carcinoid, which is a neuroendocrine tumor. And I was at risk of losing my whole lung because it was in the intersection. Dr. Flores could probably say it better, but it was in the intersection of the main bronchus, and it was in a really bad spot. So everybody wanted to take my lung out, and I guess I'm just trying to say that being an advocate for yourself, also to push for if you don't feel good. Doctors are not always right, and they were not right in my case, and if I didn't ask for a CAT scan, I don't know what would happen. If I didn't keep going for more and more opinions with surgeons, I would not have found Dr. Flores, who ended up saving my entire lung when everybody said that it was completely impossible to do. And he magically cut it out and stitched it back together. And I don't know exactly what he did, but I guess I just wanted to share that and just to say that I do believe that if it wasn't for my CAT scan, I don't know what would have happened. And I'm a singer, I'm a dancer. I was healthy my entire life, and I couldn't do anything. I couldn't breathe, and now I just made it through 7 rounds of The Voice. So I'm singing again. And
All right.
So I just wanted to say thank you. And if you don't feel well, if you're symptomatic, or if you know anybody that is symptomatic, and if doctors say you're fine, it's better safe than sorry. Get a CAT scan, or just advise them to get one. It's just can't hurt. So it can only help and save your life.
Thank you. Got to thank our panel. You guys are awesome. Some of you are repeaters, and we're going to be doing this on a regular basis. There are always new advances. Thank you. Bring a friend next time. Stay healthy. Keep asking questions. Okay? Okay.
Thank you, Roz.